Good afternoon, everyone. I'm Natalie Gawkner, and I direct the Kempsey Gardner Policy Institute. This is our home, the Thomas S. Monson Center. We're really glad you're here. This center is an embassy of policy leadership for the University of Utah downtown, and from time to time we get to host these wonderful events. Before I get started, I want to acknowledge and thank some people. First, I want to acknowledge and thank our partners at the Salt Lake Tribune for their continued partnership. This is what we call the Storytelling Through Data events. We've co-sponsored conversations before that are data-grounded, solutions-oriented, and critical to life quality in the state of Utah. In the past, we've talked about Utah's declining fertility rates, rental market constraints, and even the thriving downtown urban core. And so I want to thank Lauren Gustus, the executive editor, Megan Banta, Saren Weber. Thanks for all you do. Let's give applause to our friends at the Tribune. I also want to thank our colleagues at the University of Utah and the Mariner S. Eccles Institute for Economics and Quantitative Analysis in the David Eccles School of Business. They are pushing the frontiers of economic knowledge each day. I like to think we have a model partnership with them, a very talented faculty, and so thanks to Scott Schaefer and Adam Looney and others. Adam, raise your hand and wave there. I don't know if Scott's in the room, but let's give them a hand as well. And then finally, I want to share my appreciation for the outstanding team at the Kempsey Gardner Policy Institute. Laura Summers leads our health policy practice and directs our industry research team. Where did Laura go? Right here. I also want to thank Jennifer Robinson, Nick Thuriot, Colleen Larson, Parker Banta, Ellis Ivory, and others for helping to prepare the policy brief, which we will have for you at the end of this event, and helping to make all this happen. So let's thank the Gardner team. Today's topic is the healthcare coverage landscape. Currently, there are high rates of private health insurance enrollment, low rates of public health insurance program enrollment, and declining uninsured rates in Utah. That said, uninsured rates remain high for some populations, and healthcare affordability and access are always concerns, if not top concerns, for many Utahns. We have an expert panel today who will discuss the U.S. health insurance system and proposals for change in the context of Utah's health data, markets, and outcomes. Lauren Gustus with the Salt Lake Tribune will moderate our panel, but before we get to Lauren, we get to hear from our guest, Professor Amy Finkelstein. Amy is the John and Jenny S. McDonald Professor of Economics at the Massachusetts Institute of Technology. She's also the co-scientific director of JPAL North America, a research center at MIT designed to encourage and facilitate randomized evaluations of important domestic policy issues. Sounds like just the kind of thing we need, a lot of evidence-based random control trials and the like. Other roles include co-director of the Public Economics Program at the National Bureau of Economic Research, a member of the Institute of Medicine and the American Academy of Arts and Sciences, and a fellow of the Econometric Society. So this is really a treat for us to have Amy here today. She's received numerous acknowledgments for her work, including the John Bates Clark Medal from the American Economic Association and MacArthur Fellowship. Her latest book, We've Got You Covered, Rebooting American Healthcare, gives a lively and provocative proposal for health insurance reform. So please welcome Amy Finkelstein to the stage, and then after her, Lauren Gustus will take over with our panel discussion. So Amy, and there's some stairs over here, Amy. It's a little awkward, but if you come around here, it'll work just great.
So thank you very much for having me. I was told to speak for about 10 to 15 minutes, and I realized I don't see a clock anywhere. So you'll give me a heads up when I should shut up. So thank you very much for having me. I'm delighted to talk about my new book, which is joint with my longtime collaborator, Laurent Einev. I'm an economics professor at MIT. He's an economics professor at Stanford. And we've been working together for about 20 years doing research on US health economics. But until this book, we had sort of stayed very carefully and clearly in our narrow academic lane on doing the research and leaving it to others to try and figure out how to use, I mean, the hope was always to use that to inform policy decisions. And this book was our attempt to take a step back and say, you know, if we were freed from political constraints, not economic constraints, but from political constraints, what would an ideal health insurance system look like in the United States, with the goal that either, who knows how, you know, politics may change and what may be possible in some state at some point, or even if you're more pessimistic and think we could never get there, and you're doing the important and hard work of trying to navigate from where we are to where we want to be, hopefully we can convince you of where we want to be, so then you can figure out what trade-offs and compromises are more or less consequential in trying to get there. So the book is divided into 3 parts, you know, and I'll just talk about each of them briefly. What is the problem? What is the goal? And then what is the solution? And on the problems, you know, we identify 3 main problems. The first, which I'm sure everyone is aware of, is that despite, you know, progress, there are many Americans who don't have health insurance at any point in time. Current statistics suggest 1 in 10 Americans under 65 nationwide, at least, are uninsured at a point in time. But the second problem is that actually vastly understates the problem. If you think of health insurance not just as a static, but over a period of time, we estimate that over a 2-year period, about 1 in 4 people under 65 will spend some period uninsured, and that's not just a short period of time. You know, half of them will spend 6 months or more uninsured, a quarter of them will spend 2 years or more. And even though the Affordable Care Act that was passed in 2010 dramatically reduced the share of people who lack coverage at a point in time from about 1 in 5 to 1 in 10, it barely moved the needle on this share of people who risk spending some period of time without insurance over a 2-year period. And the reason for that is that our approach to date has been a series of patchwork policies, including most recently the Affordable Care Act and extending Medicaid, that try to provide coverage to people if they meet particular conditions or particular circumstances. And the problems are that your circumstances may change, or you may simply fail to recertify your eligibility for a public health insurance program like Medicaid, even if you're fortunate enough to be one of the half of Americans nationwide who have private health insurance. Sounds like the numbers are even higher in Utah. You still face the risk of losing that coverage if you retire before 65, if you change jobs to one that isn't offering health insurance, or if you lose your job, perhaps because you're becoming ill. And so, you know, that's very unfortunate because health insurance is supposed to provide economic security, and it itself is highly uncertain. The third problem is the problem of large amounts of unpaid medical debt that people owe. The numbers are very large, and that's been documented for a long time. What we hadn't realized till we did the calculations for this book is that the vast majority of this medical debt, 3/5 in fact, is incurred by people who have health insurance at the point in time where they're incurring those medical expenses. It's just not covering all of their expenses, and so they're left with unaffordable medical debt. And this can rise from the high deductible health insurance plans that private insurers are increasingly promoting. It can arise in Medicare for the elderly because even with Medicare coverage, people are on the hook for 1 out of every $5 of physician fees. So if you have tens of $1,000s in physician bills, for example, from oncology or something, you can end up facing an enormous amount of out-of-pocket medical bills. So those are the 3 problems that we think need to be solved for health insurance to function well. We then ask, you know, what have we been doing all this time? And we take a step back to look at the history of U.S. health insurance policy over our 300-year history, but also more recently over the last half century. And 2 things emerge quite clearly. I'm not going to go through even the examples on this slide, let alone all the ones in the book. But one is that we've had a history of policy responses in the forms of patches that come into place when a particular group gains salience and is able to gain traction for their issue. They usually revolve around people who face unaffordable medical expenses that they really need for life-saving conditions, whether it was end-stage renal disease in the 60s or migrant health workers lacking access to health care also in the 60s, Ryan White and HIV in the 80s. This is Katie Beckett and disabled children that became an issue in the early 1980s under Reagan, or more recently the Ice Bucket Challenge, which for ALS, which prompted expansions of health Medicare coverage to people with ALS. All of these have several features in common. One is that these patches come in and they're kind of inadequate because you have coverage for end-stage renal disease, but only when it reaches the end stage, not when you have chronic kidney failure, and you might be able to take some medication or get some care that could prevent it from progressing. More to the point, if you get a successful kidney transplant, and now you no longer have end-stage renal failure, you have a functioning kidney, so you lose your health insurance coverage, even though you now have to still pay tens of thousands of dollars a year for immunosuppressive drugs. They all have that sort of punching below their weight feature, but they have another important purpose, which is why we spend a fair amount of time on them in the book, which is that they illustrate, we think, what it is that US policy has been trying, albeit unsuccessfully, to accomplish. Because we feel very strongly that before we can talk about the solutions on the health insurance side, we need to first agree on the goal. What is it we are trying to accomplish with US health insurance policy? There are many things we could be trying to accomplish. We could be trying to improve population health, reduce health disparities, redistribute income, correct market failures. These are all things that people have written and spoken about. When we looked, though, empirically at what it is historically we've been trying to do, what we discovered is that all of those types of policy patches we describe and many more all come from a fundamental social contract, moral obligation, empirically, that appears to exist to provide access to essential medical care regardless of resources. Now, that may seem like a strange claim to make in a country that's famous for its independence and pulling oneself up from one's bootstraps mentality, as well as, of course, that we're the only high-income country without universal health insurance. But in the book, we argue that that represents our failure to date to fulfill our commitments, not our lack of trying and their absence. And perhaps the best example of this comes from looking in modern times at the experience of people who still lack health insurance coverage. What we argue in the book, somewhat counterintuitively, is that no one is actually uninsured. What would it mean to be actually uninsured? It would mean that any medical care you got, you had to pay for yourself. And that's simply not what happens. Research that I and others have done indicate that the uninsured receive about 80% of the medical care that they would receive if they were insured. We figured that out through randomized controlled trials of the kind that was mentioned earlier. And yet they pay only about 20 cents on the dollar for that medical care. If they were actually uninsured, they would be paying dollar for their medical care. And that other 80% isn't, GoFundMe campaigns and charitable donations. It's a host of publicly funded, publicly regulated, local, state, and federal government programs that are designed to try to provide access to essential medical care when people can't afford it. That includes public hospitals, who are required to treat indigent patients, even in non-emergency situations, nonprofit hospitals who get tax subsidies in return for providing a community benefit, community health centers that are publicly financed to try to provide primary and chronic care. And so we argue that this is a modern piece of evidence, one of many that we discuss in the book, of our attempts to fulfill this social contract. We also point to the early origins of hospitals, which sprung up really as charitable organizations at a time when medical care couldn't really do anything in the late 18th, early 19th century, because as the a historian of medicine, Charles Rosenberg, puts it very nicely, fellow creatures could not be allowed to die in the streets. There was a charitable impulse that we need to help our fellow creatures when they are ill and cannot take care of themselves. And if you either already believed, or I was able to convince you in these few minutes, or you read the book and are then convinced that in fact this is the purpose of US health insurance government policy, to provide access to essential medical care for everyone, then the solution becomes very simple. It's something that's not original to us. It's actually been recognized since the dawn of our republic, and in modern times, it has been embraced by people across the political spectrum. So to speaking of the dawn of the republic, a fun fact to take away, if nothing else from this talk, is that the first instance of national compulsory tax-financed health insurance was in the United States, and it was in 1798. It was an act for the relief of sick and disabled seamen. It was a payroll tax on sailors' wages. 6 cents per sailor per month at sea were deducted from their wages by the captain when they arrived at port and had to be handed over to the customs agent to be used to fund the local hospitals that were providing them with charity care when they fell ill at port away from their family. This had been promoted by none other than Alexander Hamilton, whom you're all familiar with, arguing that the interests of humanity are concerned from it, and his argument was these sailors become ill when they are ill and they arrive at port. They become a disproportionate burden on the local community who's going to feel compelled to take care of them because fellow creatures cannot be allowed to die in the streets, and therefore we might as well, recognizing that, formalize that commitment and fund it up front through payroll tax on their wages that's used to provide care when they become sick. And this notion that if ultimately that we are going to step in as taxpayers and provide medical care when people cannot afford it and desperately need it, that we should formalize that and fund it up front, is something that has been embraced in modern times by people across the political spectrum. It includes Republican Governor Mitt Romney, when he was governor of Massachusetts, enacted mandatory universal health insurance in Massachusetts prior to the Affordable Care Act. And Supreme Court Justice Ruth Bader Ginsburg, in upholding the constitutionality of the Affordable Care Act, made a similar argument. So if you are willing to agree or already agreed that this is the purpose of health insurance, the solution, as I said, becomes very simple. It has 2 parts. We can fit it on a slide. We'll get it on a bumper sticker. The first part is universal coverage that's automatic, free, and basic. And the second is the option for people who want and can afford to supplement in a well-designed and well-functioning market. Now, that last is what economists love to work on and think about, and we have a whole chapter on it in the book. But in the interest of time, I just want to very briefly summarize the key 3 elements of the universal coverage, which is that it's automatic, free, and basic. I think the automatic part is obvious. We've already enacted universal coverage through the Affordable Care Act. We just haven't achieved it. So the only way to actually achieve it is not by mandating that people have coverage, but by providing it automatically, as we've done with Medicare for physician and hospital payments. More controversially is the notion that this care should be free. Anything that's provided, that's essential medical care that's provided in the basic coverage should be free. And our argument there, which runs counter to a lot of standard economic thinking, is that, yes, it is true that when people don't have to pay anything for their medical care, they use more of it. And this has prompted generations of economists to argue that people should have some financial skin in the game and have to pay something out of pocket for their medical care so that they make judicious decisions. That research is correct. I've done some of that research. Many other economists have as well, and we stand by it. But my co-author and I, despite having subscribed to this view that therefore people should have cost sharing in health insurance to make them sort of financially prudent and savvy in their medical decisions, say unequivocally in the book that when it comes to universal basic coverage, we take that back. And we take it back not because we were wrong about the facts, we stand by our research and those of our colleagues, but because we were wrong about their implications, at least when it comes in the form of universal basic coverage. And the way that we know that we were wrong is by looking at what has happened in countries around the world that have listened to the advice of well-meaning economists and introduced or increased cost sharing in their basic coverage plan when faced with budgetary constraints. And it's kind of amazing. You see them introducing the cost sharing with the one hand and the exemptions and exceptions with the other hand. So they introduce small copays for prescription drugs or doctor's visits, and then exceptions if you're old, if you're young, if you're poor, if you have cancer, if you are a student, if you're a veteran. The list goes on. And the reason is because fundamentally, if the purpose of basic coverage is to provide access to essential medical care for everyone, regardless of resources. There will always be people that can't even afford small amounts of copays. And so countries find themselves back in this convoluted patchwork of customizing solutions for different people based on income, age, health status, etc. So at the end of the day, for example, in the UK, which introduced prescription drug copays, 90% of prescriptions are dispensed to people who are exempt from those copays. In France, which has famously high cost sharing in its basic coverage, sometimes as much as 20 or 30% for some procedures, they have publicly financed supplemental coverage for people who are low enough income, tax subsidies to encourage higher income people to buy the supplemental coverage to cover that cost sharing, requirements on employers to offer supplemental coverage, so that at the end of the day, 95% of people in France actually have coverage for their cost sharing. So our basic point is not that copays don't work, it's that they don't work if they're exempted, and empirically that's what happens, because otherwise the cost sharing is in tension with the very purpose of the universal coverage. The final thing I want to say is that this coverage has to be basic, and that's going to be important both because our commitment is to provide access to essential medical care, not a high-end luxury experience, and it's going to be important in terms of making this budgetarily feasible. And so it's fun to get up and say automatic, free, universal, but I want to be very clear that basic means basic in terms of non-medical amenities like semi-private hospital rooms. You might instead have 10 people to a room as they do in Singapore in their basic system. It means longer wait times than what people with private health insurance are accustomed to for non-urgent care, more like what Medicaid or the Veterans Administration has. And it means less choice of doctor or procedure than you might have under the current traditional Medicare system. So that at the end of the day, we estimate that about 2/3 of people would supplement from the basic to buy additional coverage. That includes most people with private insurance and Medicare. The basic plan you can think of as looking pretty similar to Medicaid for all, what low-income individuals have. They'd be better off because no risk of losing it, and they could always supplement if they wanted, and the uninsured would, of course, be better off. Now, the final thing I'll say before wrapping up is on the cost side of this. We estimate that you could enact this universal, automatic, free basic coverage without raising taxes for one very simple reason. Most countries spend about 9% of GDP on healthcare. Most high-income countries, I should say. We spend twice as much. We spend 18% of our GDP on healthcare. But in most other countries, almost all of that healthcare is taxpayer financed, whereas in the US, only half of it is taxpayer financed. Half of 18% is 9%. In other words, we are also spending 9% of taxpayer, not 9%, we're spending 9% of the economy on taxpayer-financed healthcare, the same as what other countries are spending to enact universal basic coverage. We're already paying as taxpayers for universal basic coverage. We're just not getting it because we have chosen instead to allocate those tax dollars to tax subsidies for employer-provided health insurance and to a Medicare system that is much more generous than the basic system would be, but only covers people over 65 and the disabled. All right, so I think I'm going to stop there in the interest of time. We talk about lots of other things in the book, including some of the politics of it, but I think this is a good place to stop and opening up for discussion. Thank you.
Oh, yeah, panelists, welcome.
Thanks.
Thank you, Amy.
Thanks.
Yeah. And thanks to the Gardner Institute for hosting us this afternoon. We are eager to engage in another data-centered, excuse me, I usually don't say my R's. I am from Massachusetts. Data-centered conversation. We've already heard from Amy, and she'll continue to share her insights as a panelist here. But I'd also like to welcome Allison and Laura for the Q&A portion of our program. Laura is a senior healthcare analyst at the Kempsey Gardner Policy Institute. Here, this is your home. And Allison is a health economist and professor at the Hughes Eccles Institute. Welcome. Thank you. One programming note, we will move to questions from the audience at about 1:10 past. So if you have questions, hold on to them, be ready, and we will
we will take those shortly. In the interim, meanwhile, I will dive in. And Laura, I'd like to ask you, we heard a lot about what we're seeing nationally from Amy just a few minutes ago. Can you give us a little bit of an update with respect to where we are regarding health insurance and coverage here in Utah today?
Yeah, absolutely. So I would say as a whole, Utah looks relatively good when it comes to health insurance and health insurance coverage. We actually have the highest rate of employer-sponsored coverage in the country, where about 60% of our population does have access to their health insurance through their employer. On the flip side, we interestingly have the lowest percent of the population that is enrolled in public assistance programs. So this is looking at data from 2022 from the American Community Survey, which is through the Census Bureau. There's a lot of different sources that you could look at for uninsured rates. We chose that one specifically so we could do the national comparisons. But looking at the 2022 data showed that in terms of Medicaid, we actually ranked the lowest in the country in terms of the population, our percent of the population that was enrolled in Medicaid. This, interestingly, was even after we expanded coverage. So we did expand Medicaid coverage in 2020. So even with that, we ranked lowest in 2022. Now, I would say the data could be interesting to see because there's a lot of factors that could influence, like COVID-19. There were issues with the census survey. So, that's based off sort of the best data we had at the time. In terms of Medicare, we actually ranked second lowest, which again I think is kind of interesting because we have such a young population, and I can't remember off the top of my head which state. Right, actually it was DC. DC has a lower share of their population on Medicare than we do. But again, a lot of that is just driven by our demographics, our economics. We have the lowest, the youngest share of the population in the country. So generally we're healthier, and that has a lot of impact on where we rank in terms of that healthcare coverage. We have seen, like Amy mentioned, the declining uninsured rates over time. In the brief, we show uninsured rates over a 10-year period, and you can really see how that has come down and how a much higher share of our population has received coverage and is enrolled in coverage over the last 10 years. And again, due to federal reforms, state reforms, as well as just our state's economy are all sort of factors that play into that. Now that said, I would say that's the broad view, and when you do start looking at individuals and individuals' access to coverage and individuals' experience with the healthcare system, that's definitely a different story. And we do continue to see healthcare access, healthcare coverage, healthcare affordability continue to be top concerns for our state and for the population in our state, which I think speaks to even with our good rankings, these are all issues that everyone in our state is continuing to struggle with. So,
thank you. For those of you with eagle eyes, you may have seen a Nevada and Utah slide that Amy buzzed by quickly, probably in the interest of time, but I thought this was really interesting. And I wonder if you would spend just a minute building on what's happening in Utah by making that comparison with Nevada.
Yeah, it was the wrong slide to skip for this crowd. So this was actually in health economics lore. This is one of the starting points of an entire field. 1974 book by the Vic Fuchs, who's considered the grandfather of modern health economics. He unfortunately passed away this fall at the age of 99 while he was working on the third edition of that book, so may we all have such a life. But in this book, he made a very, very famous comparison. He called it a tale of two states, and to give away the punchline, it was Nevada and Utah, which he described at the time as two states that were very similar in terms of their demographics, their income, their healthcare systems, but had very, very different health outcomes. And in particular, mortality rates among people of a given age and gender were much lower in Utah than in Nevada. And when he looked at the reasons for this, causes of death, he found what he referred to as better health behaviors in Utah, what we would now probably more call the social determinants of health, in particular, lower rates of death from lung cancer, so less smoking, lower rates of death from cirrhosis of the liver. And this finding has really stood the test of time. It's been replicated in much larger data sets in many other countries. And the central point that he was making, and the reason it's in our book, is that the fundamental driver of health and health disparities is not necessarily medical care or the access to medical care that health insurance provides, but it's more the pollution we are or are not exposed to, the cigarettes we do or do not smoke, the violence in our streets or not, so these so-called social determinants of health. And we bring this up in the course of the book when I mentioned very briefly, it's important to be clear on what problems we're trying to solve. The very real problems of poor health and high health disparities in the United States are amenable potentially to public policy solutions, but public health insurance policy is not the lever to lean on if you want to make a dramatic difference in health. It has much more to do with these other factors related to the environment, to health behaviors, to the environment in which you're growing up. So that was why we had that slide up there. It sounds like it's still true today.
Yeah, so Utah beats Nevada is what you're saying. Okay.
Is that going to be the headline tomorrow?
Yeah.
In 1974.
Fair.
But actually, a bunch of people redid a version of this study using like the universe of tax records, from 2020, from 2001 to 2014 or something. Utah was still doing much better than Nevada. So.
Go ahead.
And to add to what Amy said, I pulled up a map of census tracts and life expectancy in Salt Lake City this morning. And so to add to what Laura said also, is that within our state there are big disparities. And so I looked on the east side of Liberty Park where life expectancy was 80 years. A few blocks away on the west side of Liberty Park, life expectancy is 10 years shorter. So really the neighborhood that you grow up in is hugely predictive of your health outcomes long term. And although healthcare is important, it's more these social aspects.
Right, and I think one of the reasons, because it was very puzzling to me to be like, what are we really writing a book in which we're saying medical care is not important to your health? Like, what are we smoking, right? And I think what we finally came to realize is it's not that healthcare or medical care isn't important. It's that given how much medical care everyone, even the uninsured, already get, what's driving the remaining disparities is not so much medical care as these other factors. And I think one of the best pieces of evidence of it is if you look in, or other people have looked in countries like Sweden and Norway, which have universal health insurance, and if you look at the differences in life expectancy between people at the bottom and the top of the income distribution in those countries, it's as large as it is in the US.
I wanted to follow up, Allison, with you. We talked a lot, Amy talked a lot about some of the problems that underlie the solution that she's proposing. We have additional challenges when it comes to healthcare coverage in the United States. Based on what research you are engaged in, can you help us understand what else is out there that maybe forces for us to think about or to consider? What other challenges are we facing?
Sure, and I'll invite the other panelists to jump in as well at the end. I think the first thing that people think about when they think about American healthcare is just the exorbitant cost. Amy said we spend 18% of our GDP on healthcare. Canada spends 12%, England spends 11%, and so this is costing us all individually even a lot. The average price of healthcare for a family for private coverage in the United States is $25,000 a year. So that's coming out of our paychecks. It's coming to us in the form of lower wages. And so this affordability problem is really a big issue. And then sort of tied to that is the fact that we're not necessarily getting great health outcomes for the money we're spending. So if we were spending more and getting really amazing health outcomes, we might say, yeah, this is worth it. But the United States, on a number of measures, performs poorly than our peer countries. So we have the lowest life expectancy of wealthy countries, but we just talked about that there are many factors that contribute to that. But if we want to think of a couple of examples maybe that are more tied to medical care, if you have diabetes in the United States, you're much more likely to have unavoidable hospitalization. Also, our maternal mortality rate is extremely high. It's terrifyingly high. And maternal mortality is largely preventable. We're kind of on par with countries like Latvia, Ukraine. It's not usually who you think of as a peer country to the United States. And so I think the sort of dual problem of high costs and we're not getting much for it is the big picture problem.
Others want to jump in there?
I was just going to add, and I think this relates to additional challenges that we're facing, and it maybe brings in some of the Utah context, as we were just talking about sort of the social determinants of health or health-related social needs. I think two things Utah should be thinking about explicitly when it comes to sort of the healthcare coverage landscape. Even though we rank really well, or pretty well, relatively well, in terms of our insurance coverage and access to coverage, certainly our increasing housing costs, and as housing becomes more unaffordable, not only does that impact or have a potential impact on people's ability to afford health care, but we also there's a lot more research around how important housing is in terms of being able to engage in medical care and make sure that you're getting your treatments, have access to treatments, can regularly receive treatments. I think just the other thing, and this gets more into sort of the rural lens, is around our potentially shifting economies in some of our rural areas. As we think about natural resource changes, energy changes, things like that, we could have some of our rural areas could be seeing some, changes in their industry over the next few years, next 10 years, next 5 years. And what does that mean in terms of access to coverage? As those industries change, are replaced, will the new industries come in? Will they offer as good a coverage as is available now? I think that's a question, but again, thinking about broader than just the healthcare system, health insurance, and thinking about Utah, I think some of the things that will really rise up over the next few years will be our housing costs and then our shifting economies in especially some of our rural areas. So,
thank you. Amy, we heard $25K a year for health insurance. At the Tribune, before we start reporting on a story, we like to think about what it would mean to a listener or a reader if this thing were to happen, right? And so my question is, what does it mean to me, who has health insurance, right, if we were to be all of a sudden living in your book, right, in the new world? What changes do we see? Is it a change in that $25K that I'm paying? Help us understand what it would mean for individuals under your proposal.
No, that's a great question. I'd say for individuals who have private health insurance, the two key benefits of our plan is because it's going to provide automatic, universal, basic coverage for any essential medical care. It means, one, you don't have to worry about losing your coverage if you lose your job or change your job or want to go freelance or want to retire early. It also means that anything that's covered by that plan, you don't have to worry about getting faced with potentially crushing out-of-pocket medical bills because you have a $3,000 or $4,000 deductible in your plan. Would it change your healthcare costs, though, that $25,000 number? No. Why not? It's not. I mean, I agree with everything that was said, that both the U.S. spends way more than other countries and has very little to show for it. There is enormous consensus that there's enormous waste in the U.S. healthcare system. Estimates put it at about $30,000 or $40,000. But it's like that, old joke about advertising, that half of all advertising money is wasted. We just don't know which half. I think, unfortunately, right now, the state of knowledge with healthcare spending is we agree that there's a lot of waste. We even agree on what the broad pockets of waste are: unnecessary care, high prices, administrative costs. But policies or proposals that would attempt to tackle any of those all come with reduced access to medical care. That doesn't mean that isn't something we should potentially be willing to pay for or to support, but there's no free lunch or panacea, at least that we've been able to find yet. And so what we do in our proposal, most health policy proposals try to tackle these two twin problems, the insurance problem and the spending problem. We would too if we knew how. But our point is, our sober take on the evidence is we don't have a silver bullet yet, or even a bronze bullet for how to really meaningfully reduce healthcare spending without potentially harming patient outcomes. So let's at least, our goal was to focus on the problem we felt we did know how to solve, that we could solve without at least increasing that second problem, and hope that what we and others can do next is work on this huge inefficiency in the healthcare sector to bring that $25,000 number down.
I'm interested, Laura and Allison, if you've got thoughts on how a proposal like Amy's would change healthcare's, landscape here. You talked about rural, we talked about the cost of housing. What would it do in Utah, given what we know, what you shared with us, Laura, earlier?
Yeah, and I think, a lot of it is sort of in the details in terms of like what would basic coverage look like, what would the cost be, and I think those are all sort of questions that need to be, answered or figured out for the state of Utah. In terms of the benefit, I do think it would be helpful in terms of the uninsured population that continues to exist. You mentioned that even the numbers can be misleading in terms of people who are uninsured at any point in time. For folks that continue to be uninsured for whatever reason, and or folks that are just above the eligibility threshold for Medicaid in particular or other public programs, I think it would be very beneficial for those individuals because they wouldn't have to worry about the churn, they wouldn't have to worry about falling off insurance, they wouldn't have to worry about not being able to get insurance because they're earning more money. And then I think the same for just any employers as well, as you think about job changes, what, a part of that factor, a part of that calculation is, what does my new insurance look like? Are the benefits going to be robust? So I think it could help simplify a lot of that, help simplify a lot of the administrative burden that comes with a lot of these decisions, both by employers and employees and, the government as well. But again, I think, in terms of individuals, I think there's a lot of questions that still remain around. Will my personal coverage be as good under the new proposal? Will my access to quality care still be as good? I imagine, individuals would probably have a lot of questions around what that would mean for them personally. So, would I still have access to my doctors? It would be a big one. So.
Yeah. So Amy's plan is basic coverage with the option to top up or buy private plans. So I think that 60% of Utahns who have employer health insurance right now would probably buy top-up plans. And like Laura said, how would that change access to doctors, et cetera? And then as far as the people who are uninsured or on Medicaid right now, I think we have some recent data on their preferences from this really interesting survey that was done by the Utah Department of Health and Human Services. So we just went through a big Medicaid disenrollment starting last year. Thousands of Utahns have lost Medicaid coverage. We had a freeze on disenrollment during COVID, and then that period ended. And so DHHS did a survey of people who were disenrolled. And what they found is that 80% of those people said that they would sign up today for Medicaid again if they were able to do so. And so I think there is an appetite for a basic plan for people who are on the lower income level.
Thank you. Thanks. All right. I said we'd open it up. Does anyone have questions? All right. Go ahead. Yes.
I'm John Pullman. I'm working. I'm with the One Utah Health Collaborative. Its relevance is we're trying to find system-level change at a state level. And I think the question I have, I know you're not a politician, but this is obviously a very political thing, but I think I can put this into an economic context.
Thanks.
A change there are winners and losers, right? We just kind of talked about the patient perspective, how they might look at it. The Affordable Care Act was heavily driven by their other stakeholders in healthcare, right? The hospitals, the insurance plans, pharma. In this model, who are the winners and losers? Essentially, like, who would be your advocates and distractors? And maybe you can just put that in economic terms, financially winners and losers, and we kind of translate that into the politics.
Yeah, no, it's an important question. I think I can do that both on the patient side and on the provider side. On the patient side, the big loser in some sense. And how would you get automatic basic coverage without raising taxes? Well, we take a lot of the money that we currently spend on Medicare for people who are 65 and older or disabled, which is much more generous than the basic coverage would be on many dimensions, and instead use that to sort of level the playing field and provide automatic basic coverage. So I'm not hopelessly naive, just somewhat naive on the politics. That's like not something I think that would play well, right? But presumably, our goal in this book is to try to see if we can convince people about what the ideal would look like. Maybe that means you phase it in, over time. So obviously you don't want to take benefits away from current Medicare enrollees or almost about to be Medicare enrollees. Or maybe you decide, well, we'll spend more money, raise taxes, or cut spending elsewhere, and level up rather than level down. So that's one set of questions. The other thing that I think your comment gets at is, what about on the provider side? Our hospitals, it relates to, am I going to still be able to see my doctor? Like, our hospital's going to get paid more or less. What about physicians? And the short answer is, actually, there are ways of implementing this plan in which effectively nothing changes for people, say, with private insurance, in the sense of, currently they get the employer pays their premiums, or most of them, and that doesn't get counted against their taxable income, so that's a tax expenditure. Instead, they would basically effectively have a voucher that says, if you want to leave the basic, you're automatically enrolled in basic coverage. If you want to supplement, you get a voucher equal to about how much the government expects they would have spent on you in the basic coverage, and you can just contribute that towards your current private insurance plan, in much the way that about 40% of Medicare enrollees opt out of the public traditional Medicare insurance and go to a Medicare Advantage plan with this voucher-like feature. It just all happens in the background. So from that perspective, commercial insurance rates, the share of people receiving those rates wouldn't have to change, and nothing really would necessarily, if you think about this as just Medicaid for all as a base, but everyone who has private insurance or Medicare is going to top up, it's really just, from a provider side, getting the 10% who lack insurance at a point in time coverage. Now, that's a good thing if you're a healthcare system and worried about massive disruption following, rejiggering 20% of the economy. It's a bad thing, though, if you are very concerned that the US healthcare system has an enormous amount of waste in it, and our proposal is going to do nothing to change that. I think, as I said, we're not changing it because we don't know how. The flip side is, it doesn't have to be disruptive to anything on the provision side.
Yeah. Okay. Let's go right here.
A number of your comments focused on the impact of, if you will, lifestyle, economic disparities between East Side, West Side, the fact that current coverage for things like end-stage renal disease happens when you reach that end stage. So my question, I guess, is to ask you to comment on what can be done from a policy perspective, et cetera, to, if you will, focus on prevention rather than the care piece, with regard to decreasing those disparities, those not getting care until it's too late, if you will.
Yeah, that's a terrific question, and it relates to something we grappled with a lot in our proposal, because as we discuss in the book, our argument is basic coverage should provide the types of things that the taxpayers ultimately step in and provide just too little, too late when people are sufficiently ill. But most of that revolves around acute crises, like when you're sick, when you have the end stage, renal failure, and there's much less on the chronic or preventive side. And this it turns out is a psychological bias, or at least psychological phenomenon, that you see in many different types of policies. So as we talk about in the book, people have written about, you see the same type of thing, for example, in federal disaster relief policy, that there's a huge outpouring of support when a hurricane hits, to public support to send FEMA and taxpayer dollars to do something, for example, following Hurricane Katrina, but little public support to spend money to alleviate the sort of chronic poverty conditions that existed that made people in the low-lying areas of New Orleans particularly susceptible to flooding. So if you were literally following our prescription, the letter of our prescription, you might say, well, why should we cover primary and preventive care? And we spent a lot of time, because we thought that was idiotic, but like trying to understand what was a coherent reason for that. And there's a lot of arguments being made that covering preventive care can save money. And I was very against putting them in the book because A, I'm not sure that evidence is correct. Part of it is it's complicated because if you save people's lives, that can cost more money, right? Because then they live to get other things. The bigger point is I think it's just the wrong metric. We do things because to help people, not because we want to save money. If we wanted to save money, we could just shut down hospitals. That would save money. And so our argument for covering primary and preventive care in the basic coverage in our book is just, if we're going to fund the Coast Guard to rescue ships when they're sinking at sea, wouldn't it make sense to also fund like the lifeboats on the ship and check before it sets sea that it's not leaking? So we had a much more sort of pragmatic common sense, and also it's really cheap. That part is true. So even for the privately insured, who have coverage for primary and preventive care and are getting the most of it, it's 5% of medical spending. So this is not where the huge inefficiencies and concerns about overspending are coming from. So we very much support covering it, but we're not going to go so far as to say we should cover it because that's going to save money. We should cover it because it's the commonsensical thing to do, that if we're committed to helping people once they become ill and it's relatively inexpensive, why not also try to help them from not becoming ill?
Thank you. I think we're over here. Yeah.
Hi, I'm Dr. Jarvis, the one who got beat out at the start. I am glad to hear you talking about commonsensical approaches because I chair a group called Common Sense Healthcare for Utah. You refer often to what you're proposing, or several times today, as Medicaid for all. Medicaid, of course, being a state and federal shared program. It implies that this could be done on a state level. This could be achieved, although I'm not sure that your book makes that clear. So first of all, can we do basic health care for everyone at a state level, say here in Utah? I'd like all three of you to comment on that. And why not call it what it is, since it's publicly funded, automatic enrollment, basic care for everyone? Why not call it the state-based single-payer approach?
So that's a great question. The first is it absolutely could be done on a state level, and I do think we have a sentence on that in the book. We don't go into it in detail, mostly because we try to leave how we get there to people who know more. But absolutely, I think if you look at the history of health insurance reform and health insurance progress in the US, most of it has been ideas that started at the state level. So I would be delighted if a state were interested in doing this. Let me just quibble slightly that it doesn't have to be single payer. It could be single payer, like the UK system or the Veterans Administration system, but it could also be multiple private payers like Switzerland or the Netherlands. So it has to be universal, automatic, basic, and free, but there are different ways one could structure the provision of it. Single payer would be much more disruptive, perhaps is a good thing or perhaps is a bad thing to the existing way in which physicians and hospitals are reimbursed. It could be done without that. So it doesn't have to be single payer. It could be single payer. And I'll leave the people who want to enact it in the great state of Utah to fight over that detail.
I think Amy covered it pretty well.
Yeah, I was just going to add, I don't, from a mechanics perspective, I don't, I'd leave that to the experts that have really looked into this. I would say maybe just from the benefit perspective that there could be a lot of advantages of thinking about Utah doing this, or at least taking steps toward this, more from the creating a system that works best for the state of Utah, in terms of what does our demographics look like, where are our needs, where are access issues, where are affordability issues. So that's certainly, I would expect or guess that that's easier done at a local level rather than taking it on at a broad US level. So there could be advantages just from thinking about it in a Utah context.
So I'm going to throw a spanner in the works. Number one is I'm a liver transplant hepatologist and work for not the University of Utah, but for Intermountain. And I'm going to compare Nevada to here to go back to the question of who would be the payer. and then ask you to comment. So Nevada's healthcare system is very fragmented. Here in Utah, what separates it from other healthcare systems is that you have two very large integrated healthcare systems, and Nevada has none, 0. And so that drives one thing, but the other part is reimbursements for physicians in Nevada from their payers, their private payers, are 20% below Medicare, as compared to here, where they're above Medicare rates. So with that in mind, could I get people to comment again on how you would implement this? Because I come from a foreign country, which hasn't been mentioned yet, but it's Australia.
We talk about it at length in the book.
Yeah, it's got a very nice integrated system, as you point out. And so what I'm trying to work out here is that when you have too many groups, how do you address the fact that too many groups are organizing too many different contracts when you're trying to make one simple design? But if you could comment on that.
I'll try. So I do agree completely that a simpler system is one way to sort of keep costs down. Even in places that have private coverage, so like in Germany or Switzerland, they have a single price for a procedure in a geographic area, right? And in the United States, our prices are pretty secret and fragmented. You can have different prices for the same procedure at a different hospital depending on the insurance company they contract with, or down the road at a different hospital, something can cost twice as much. So I do think the unique landscape in Utah, apart from our demographics in terms of being very young and very healthy, also the nonprofit healthcare systems can keep costs down.
Yeah, I guess I was just going to, once again, try to separate the coverage from the delivery. And to be totally honest, I think I have heard arguments on both sides that, multiple systems means more competition, more innovation, single systems means more efficiency. Genuinely, we didn't leave it out of the book because we wanted to save something for the sequel. Genuinely, I think the evidence is not clear, and I think reasonable people can and will disagree. I would love to see in Utah or in any other state this universal automatic basic coverage, and I would have to listen hard to what people on the ground said about whether they wanted to do that through the current set of providers that you have, through a more fragmented system like Nevada, through a less fragmented single payer system. I think there are arguments to be made for all of those, and I genuinely, I hate to sound wishy-washy, but I'm convinced in my wishy-washiness.
Well, we've got about time for one more question. Yeah, go ahead. Yeah.
So I'm pretty loud. So thinking about the topic storytelling through data, the data landscape in healthcare is going to shift incredibly between 2100 and 2000, right? We're going to have trillions of data points, Fitbit monitors, we can assess our own genetic risk for certain diseases. What do you think the healthcare system of tomorrow is going to look like, and how would we build that instead of building a system from 2000 looking backwards? And I think some think that technology solves all problems, and the AI bots will make doctors have no errors, and whatever the context. What is your picture of how healthcare will change with that kind of landscape?
It's a great question. I wasn't there the day in grad school they handed out the crystal balls. I'm not good at forecasting. I mean, I'm stunned, just to take one example, it's not about AI, the new weight loss drugs offer the potential to just radically change the entire, concerns about obesity, and with it, costs of, and suffering from diabetes, from heart disease, et cetera. We've also seen, just because it's been invented doesn't mean it's spreading and being taken up. So I guess my not very interesting answer is I'm kind of trying to solve for the system that I know or can reasonably forecast, and we'll have to deal with what comes when it comes. Hopefully it will be things like weight loss drugs that make things better. If there's a technological change within the next 100 years that makes all of what I'm saying just completely obsolete, because now we can all just look at our Fitbit, press a few buttons, and with no get perfect medical care at no cost, and we don't need insurance, I'm happy to consider that a win, and I'll send my books to the remainder section. But until then, I think we just soldier on the best we can.
No one else wants to tackle that one. Yeah. Okay.
I was just going to say healthcare is complicated. That's my closing statement.
All right.
That's that. Yes.
Well, thank you, Allison, and thank you, Laura, for helping us to understand what is happening here in Utah today. And thank you to Amy for showing us another way. Nick would like to remind you that there are briefings in the back of the room for you to take on your way out. There's some great data in there. I want to thank the Gardner Institute again for this partnership, and thank you all for coming today. Thanks.